Wake up. It's the Sleep Unplugged podcast with Dr. Chris Winter, episode 39, Sleep and Narcolepsy Part 2. I want a new drug. Welcome, everyone, to the Sleep Unplugged podcast. My name is Dr. Chris Winter, your host, neurologist, and sleep specialist. If you're new to the podcast, welcome. If you're a veteran, welcome back. It's been a busy week. Our last episode, episode 38, about caffeine was huge, as I thought it would be. And that gives me a lot of excitement and happiness to know that individuals out there are as excited about caffeine as I am and coffee as I am, and really appreciated your comments about the show. They were very useful and helpful, and at times really funny. And I think what we're going to do is I get a lot of really awesome, funny comments that I don't put on the show just because I don't feel like they're carrying the show forward. But I think once a year, we're going to have to do a best of comments. Maybe it'll be around April. It'll be the tradition around April Fool's Day to do the best of the unhelpful and useless comments that aren't pushing the show forward necessarily, but really illustrate the humor of the Sleep Unplugged family. So if you are new to the show, we usually start the show with some comments, questions, concerns. I'm going to start with a correction in our last episode on caffeine. I was talking about caffeine, and then I was talking about adenosine. And as I was talking about adenosine, I said that adenosine was an adenosine receptor antagonist. And I think it was pretty clear from the context that I meant caffeine is an adenosine receptor antagonist. Obviously, adenosine wants to bind the adenosine receptor, so it's probably not going to antagonize itself, but caffeine is that antagonist. So just to be clear, when adenosine binds that receptor, that adenosine receptor, it promotes sleepiness. Caffeine works as a adenosine receptor antagonist, preventing temporarily adenosine from binding that receptor. So if it can't bind that receptor to make us sleepy, we feel more awake, at least temporarily. So I wanted to get that corrected. I always hate when I make a mistake like that in a podcast, but I just want to make sure I clear that up. I think it was obvious, but anyway, I want to make sure. So in terms of listener comments, I wanted to read one, and this came from, it's Vitas, VYTAS Yoga. And Vitas Yoga, who I believe is associated with FitOn, who I have just announced I'm doing a FitOn class about sleep. So if you're looking for more information about sleep, find the FitOn app and you can sign up for my class. It's called Better Sleep 101. And I'll just put out there, I do have a financial connection to that. I was paid to do that class, but I'm not paid if you sign up for the class. So this individual writes, what do you think about GHB, or gamma hydroxybutyrate, for sleep? Studies show it increases delta sleep without suppressing REM sleep. Aside from its propensity for abuse, seems like an amazing sleep drug. Thoughts? Really appreciate that. And it's a perfect question. Couldn't have asked for a better question leading into today's episode. Before I get into it, a couple things. Number one, my alma mater, University of Virginia, has gotten bounced out of the NCAA tournament in the first round. Really sorry to hear that. I'm not a huge sports fan. With every passing year, feel like my university days are further and further behind me. But I just happened to kind of catch it online and was reading some of the listener viewer comments, in certain platforms about unfortunate mistake that one of the UVA players made, Kihei Clark, who's been on the team for a very long time and is sort of a point guard, I think, and just couldn't believe the nastiness that was being directed at him. He made a mistake. My God, I've made 20 mistakes today alone. And I just don't think anybody deserves that kind of criticism. This is not your basketball team. This is his basketball team. This is Tony Bennett's basketball team. And if you can learn anything from watching a UVA basketball game, watching the UVA players, watching Tony Bennett, who is an outstanding individual, You understand that we win and we lose all the time, and it's important to lose with grace and with honor, and to understand that these individuals are not there to please or to satisfy you, but to grow themselves. So I hope everybody who cares about these types of things will understand that they don't need your criticism. They need your support and your love. It is a game where you're putting a rubber ball through an iron hoop. So here we go. If you're listening to the show, you know that we have a very selective guest list of people who will never appear on the show. So we don't have guests on the show, but there are 3 invited guests at this point. As we're at episode 39, we've invited Jada, we've invited Brad Pitt, and we've invited Celine Dion. They have an open invitation to be on the show anytime. And I'm going to extend a rare fourth request or an interview invitation to be on the show to Kie Clark, the wonderful, dynamic, well-rounded individual who has unfortunately played his last game for the University of Virginia, but I'm sure he's on to brighter and more awesome things. And he is, in the view of the Sleep Unplugged family, way, way more than one play in one basketball game. We wish you the best, Kihei. We are big fans of yours here at the show. So before we get into it, we'll touch on the song in the title today, I Want a New Drug, by Huey Lewis and the News. Wonderful group. This was a big group when I was growing up. This album that I Want a New Drug came from was the 1983 release Sports, which was still one of the biggest pop albums released of all time. And I Want a New Drug was, I believe, the second single off that album. I believe Do You Believe in Love, another great song, was the first single. This was the second. And I remember feeling like it was kind of a scandalous song. I Want a New Drug. And I remember distinctly the video, especially with the point where he puts his face underwater and the camera's underwater, and you can see Huey Lewis kind of, singing with his head under the water of like a sink or something like that. Huey Lewis is 72 years old and actually stopped singing and recording for a period of time because of Meniere's disease. It's sort of a debilitating neurological disease that affects the inner ear, causes tinnitus, ringing in your ear, hearing loss, and in some cases, crippling vertigo. And when I was researching quickly a little bit about Huey Lewis before we started the show, I saw that he had actually released an album in 2020 called Weather. And I remember seeing him interviewed saying, I've got this idea for an album, but this Meniere's popped up and it's completely screwed me up because of the Meniere's disease, so we're not going to do it. And the joke was his third album, Sports. This album, I think, is their 10th studio album, Weather. So it's Sports and Weather. So Huey Lewis and the News, Sports and Weather. I love stuff like that. But anyway, I Want a New Drug was a huge song. And what a lot of people don't know about the song is that when Ghostbusters came out and Roy Parker sang the Ghostbusters theme song, he was actually sued by Huey Lewis saying, that's actually I Want a New Drug, just with different lyrics. And when you listen to I Want a New Drug and then you listen to Ghostbusters, you'd probably be like, yeah, those are about the same song. So apparently they settled out of court and everything was buttoned up, non-disclosures. But Huey Lewis was interviewed on some sort of show like VH1 Behind the Music and said some things about the settlement that apparently may have broken the non-disclosure agreement that they had. And so he was actually sued by Roy Parker because of that. So anyway, a little trivia there. Huey Lewis and the News, we're big fans of you on the show. And I'm feeling generous today. We're going to extend our 5th invitation to be on the show to Huey Lewis. We're so happy you've recovered from that neurological problem. Me as a neurologist, love to hear people get over problems and not succumb to them. And Meniere's is a rough one for a lot of people. So congratulations. Glad you're back out on the road. Go see Huey Lewis in the News when you're on tour. So this is the part 2 of an episode we did. Episode 26 was on narcolepsy. And we talked about what narcolepsy is and maybe more importantly, what it isn't. We talked about the pathophysiology of narcolepsy and what's causing it. And we also talked a lot about the problems and the way that we diagnose it. What we didn't talk about in that episode that I wanted to talk about in this one was, what do we do about it? How do we treat it? Hence the I want a new drug. And I love the I want a new drug for a reason, because a lot of people who've been lucky enough to be diagnosed with narcolepsy, in my view, are getting inadequate, subpar treatment. And I'm going to explain what that means in just a minute. So I want to put a disclosure out before this episode, and I put it out in episode 26, which is I do work, consulting work, speaking work for pharmaceutical companies that make narcolepsy medications, specifically Jazz Pharmaceuticals, Harmony Bioscience, and Axsome. I've done work with others, but in terms of active work today, those are ongoing. And what that means is I will often do consulting for these companies about their medications for narcolepsy, ways that they can educate providers who treat and diagnose narcolepsy, and we'll often go out and speak about the medications to providers of sleep medical care. And I do that for a lot of reasons. One is there's a lot of misunderstanding and problematic thinking, even among sleep doctors, about these medications. And I feel it's very important that if I can have a platform, I can go out and talk to providers about, hey, these medications are very helpful in some people. They can be life-changing in some people. And these are drugs that are not to be feared. So, and I'll talk about some of the perceptions and the things that I feel are problematic as we go through this episode. So I just wanted to let you know that I am being paid to do certain things by these companies, but I am not being paid to do this episode of the podcast. But I do think those disclosures and transparency are extremely important. So the other thing that's very important to understand is I am not speaking on behalf today speaking on behalf of any of those companies that I've just listed. So my work for them is completely separate. This is my own podcast. They will probably have no idea that I'm doing this podcast, but I just want to make sure you understand that I'm completely separate here in terms of what I'm saying. So let's get into the treatment of narcolepsy. First and foremost, I think it's important to understand that you don't have to treat narcolepsy. If you have narcolepsy and you have that debilitating sleepiness that goes along with it, or episodes of cataplexy that happen, this is not something that you necessarily need to treat like atherosclerosis or angina or atrial fibrillation, that's putting you in danger. I would say outside of being in danger of falling asleep doing something dangerous like driving a car, this really doesn't really create any sort of health related problem that way. Now, if you're asking me, Chris, how many patients do you have who you've gone through this process, diagnosed them with narcolepsy, talked to them about narcolepsy, and they said, great, really appreciate it, nice to know what's going on, but no, thank you, I don't want to be treated. I don't know that that's ever happened, but I always make it a point to offer that to anyone who's there. This is your life. If you choose to have terrible vision and not wear glasses or contacts, that's up to you. I would think that would be hard, but again, it's your choice. So I just want to put that out there at the beginning, that patients who have narcolepsy don't need to treat it. Now, could you get by without treating it medically? Yes, maybe. There are some individuals who can have strategic naps during the day, and that can be extremely helpful. There are certainly patients with narcolepsy who choose to either not take medications or come off their medications for a period of time. So those individuals are not being treated. I think it's difficult. I think it's very difficult to have the debilitating sleepiness that we talked about in episode 26 and not use medications. And one of those medications that we talk about is GHB. So I'm going to get back to the listener's question. If you want to interact with the show, you can interact with me, Dr. Chris Winter, Instagram, Dr. Chris Winter, Twitter, Dr. Chris Winter, TikTok. Do not go to Dr. Chris Winter, Titter, That is an app that this show has no relationship with and would advise you not to type into a search engine. And if you do, you might want to clear that history. So let's talk about the medications for narcolepsy. So a patient said, look, okay, I've been diagnosed with narcolepsy. I hear what you're saying about not treating it, but that's not what I want to do. You know, most patients are very excited to be diagnosed with this condition because there is something you can do about it. So when we talk about medications, I'm going to start with sort of the earlier medications and work to the more contemporary ones. The older medications that we typically use are medications that I would consider to be traditional stimulants. Medications like Ritalin, medications like Adderall. These are traditional stimulants you've probably heard of in relationship to attention deficit disorder. You may know people who've taken these medications, maybe you've taken them yourself. These medications can be useful to people who have narcolepsy. Generally speaking, they're not going to be the mainstay of therapy for most people, but they can be. You know, it really depends on who you are. These are older therapies and therapies that most patients with narcolepsy, if they're diagnosed, will be offered at some point. What I typically find with these medications are they're not the foundation of an individual's treatment, but they tend to be sort of add-on, meaning that if they're having a difficult day and the medications that they typically take are not working, they have these medications like Adderall that they could take to sort of, help them out. So, an individual wakes up and takes their standard medication, maybe a little bit of Adderall, but they have that Adderall they can take in the afternoon if they have a long day, if they need to do it. I would say that when you look at narcolepsy patients, lots of them are being offered drugs like Ritalin and Adderall. And if we're looking at sort of statistics, I would say that overall, these are not the most useful medications for patients with narcolepsy. If you're looking in terms of generalities, what is the problem with them? Well, the problem is they tend to be very alerting. So they can lead to sort of anxiety, appetite suppression, jitteriness. What a lot of people don't like about them necessarily is the way they feel on them, and really don't like the way they feel when they're coming off of them. So there is some sort of tolerability aspect to these medications, but I certainly have plenty of patients who say works well for me, or plenty of patients who say, yeah, I don't really like the way I feel on them, but when I take that medication, I don't fall asleep during meetings. So I'm going to tolerate feeling a little jittery, a little anxious, because using these medications allows me to feel more awake during the day. I'm not going to spend too much time on Ritalin and Adderall because a lot of people get offered those medications. And the problem with that is when I see patients who come from other providers sometimes, so when I'm doing a second opinion or somebody's driving a long distance to come to see us in the clinic, a common story that we hear is, hey, I was diagnosed with narcolepsy about 7 years ago. Okay, great. What are you taking? I'm taking a small dose of Adderall. Okay. Did you try the other medications for narcolepsy and they just didn't work? Or, where are you at with those? No, I've never been offered anything but Adderall. And that's surprising to me and very upsetting for a couple reasons. I'm going to flash back to the mid 90s when I was in medical school. I was very fortunate to be accepted into Emory Medical School out of college. I still maintain that it was a clerical error, but I'm not going to go digging too deeply into that situation. I remember being in an Emory University classroom when medical school got started. And I remember a professor standing up there. I had my notebook. I was taking notes. This was back when you had notebooks, not laptops. And they said something on the order of, we don't want to harm patients. And I wrote that down. Okay, do no harm. That's pretty easy. Like I literally wrote it down. I wish I still had that notebook because I remember writing that down as if there might be confusion later on the test where the test question is true, false. We should harm people. And I'm like, oh my gosh, I remember this. I wrote it down. What was it? I think we're not supposed to harm people. But anyway, I remember something like the second thing they said was, we're not going to have relationships, romantic sexual relationships with our patients. And I remember thinking, well, so far medical school is very easy. And then they said, we don't want to be paternalistic. And I remember thinking, oh, I don't know what that means. I think it means something like being like a parent. And that's exactly what it means. Paternalism means we're not making decisions for our patients. We're making decisions with our patients. So when somebody says to me, I've had narcolepsy for 7 years, and the only thing I've been offered as a treatment is Adderall, and I'm still feeling pretty tired. One of two things are going on. Number one, their former provider was unaware that there were other medications for narcolepsy. That's bad. That's bad that you would be a sleep physician of some sort or providing sleep care and be totally unaware that there's at least 6 or 7 other medications for narcolepsy. What's even more problematic is that you are aware that there are other medications, but you're not discussing those medication options with the patient. You're making a decision that those medications aren't right for the patient. And I think that's extremely problematic. That's paternalism. That's making decisions for a patient that don't involve a patient. And I think it's very important right now at this point in the show that if you have narcolepsy and you've never been even made aware of the full complement of medications that are out there, I might get another opinion. I might seek another sleep doctor, because either your doctor doesn't know what they're doing or does know what they're doing, but they're not letting you in on the thing. So listen, it's hard to involve somebody in a decision-making process when they don't have that knowledge base. I always think about going to a mechanic, and I have a lovely mechanic. His name is Bob. He's in Charlottesville, and Bob will walk out with some piece of equipment that is black and corroded and show it to me and say, Chris, I don't know about this carburetor. I think that's a car part. Take a look at it. I think we probably need to replace it. And I appreciate Bob bringing this piece of metal out to the waiting room and showing me, but I have no idea what he's showing. I mean, this could be any piece of equipment that he is providing me, but he's trying to involve me in the process, even though he's got the knowledge base. So I think as doctors, we always need to be striving to think about ways to provide information to our patients. And I think helping to sort of lay out the medications available for narcolepsy can be very useful. And those medications are the Ritalin and Adderall, which we've talked about, sort of the traditional stimulants that have been around for a long time. And then many years ago, we came out with a medication more specific to narcolepsy sleepiness. Now, Adderall, Ritalin, and this medication, modafinil, are only treatments for the excessive sleepiness part of narcolepsy. Modafinil, it was called Provigil when it came out, was a much more selective medication, worked through dopamine, and was a real breakthrough for patients who have narcolepsy, generally taking somewhere between 100 to 400 milligrams a day. And it did a fantastic job of improving excessive sleepiness. So, what are the downsides of it? Well, the positives were it worked. The positives were it was generally well tolerated, but like a lot of medications for narcolepsy, nausea, sweating, weight loss, anxiety, all those things tended to go along with it. And there were a couple others that were unique too. One was there was a thought that it could affect the metabolism of certain hormonal birth control pills, making them less effective in terms of contraception. So if you had a patient who was taking birth control pill to control acne or regulate periods, probably no big deal. But if this was the one thing that they were relying on to prevent themselves from having a baby, you might want to use another form of contraception using this medication and not just rely on what you were using. And that was always a difficult thing to navigate. More recently, there has been some information coming out of Canada that says, look, this medication, and I think it's called like Allertec or something like that in Canada. I'm gonna have to look that up. Sorry, I'm speaking off the top of my off the cuff here. It's got a different name in Canada, but it's still modafinil. That it was associated in some registries in Canada with birth defects, and that's troubling. We don't want anybody to get pregnant on these medications, but these things happen. So this is something for individuals to be aware of if they're on modafinil or modafinil, that there may be some relationship between the use of that medication and birth effects. There's not a lot of information about that I'm aware of. If there is some more information that I just haven't come across, I will post it on Instagram and some papers there too. But outside of that, Fantastic medication. We've had really good success with it. Medication generally that's taken when you wake up in the morning. So outside of modafinil, armodafinil, Adderall, Ritalin, there is oxybate. Oh, and I should mention modafinil and armodafinil. Armodafinil was a variant of modafinil that came out, lasted maybe a little bit longer, perhaps fewer side effects on the medication, and the dosing was a little bit different, up to 250 milligrams. Now, both modafinil and armodafinil are generic now. Both are FDA approved for adults with narcolepsy, but also shift work disorder and refractory sleepiness with sleep apnea. Those medications do not touch cataplexy. So another medication kind of came along many, many years ago, gamma hydroxybutyrate. And that was the question that we got at the top of the show. Hey, what about gamma hydroxybutyrate? It seems to increase deep sleep. And outside of it's some of these other issues with addictiveness and whatnot, could be a great medication. Well, gamma hydroxybutyrate been around for a very long time. It was often used as a sedative or a sleep aid many, many years ago. It can be sometimes abused by bodybuilders. So bodybuilders sometimes use GHB. And the other thing that you might have heard about GHB or gamma hydroxybutyrate is that it's a date rape drug. I remember being at Emory University in Atlanta, Georgia, and they would often talk about Georgia Homeboy in the emergency room. And you're just a medical student trying to get out of people's way. I just assumed that Georgia Homeboy was some sort of gang because of the context it was always being used in. You know, people would come out and they would be beaten up or assaulted or unconscious. And I thought, and they were like, oh, it's Georgia Homeboy. I'm like, man, this Georgia Homeboy gang is pretty bad. Well, they were talking about gamma hydroxybutyrate, which is a drug that has a very short half-life, works through GABA B, creating sedation. And that medication can be very useful as a medication for a date rape because it works very quickly, causes very fast sedation. Half-life is very short. And by the time an individual gets to the emergency room, the drug is pretty much gone. It's out of your system. So it's not really easy to find. So many, many years ago, it became clear that individuals who took this actually did better when they had narcolepsy. Along came some other pharmaceutical agents, and I'm going to fast forward through all that to today, where Jazz Pharmaceuticals markets this drug as Xyrem, and more recently a version called Xywav. So Xywave is sodium oxybate, Xyrem. So oxybate is the active ingredient in this medication. It's working through gamma B to promote both wakefulness during the day and suppress cataplexy. Now, remember from episode 26, cataplexy is that sudden loss of muscle tone because the individual's entering into REM sleep. So individuals with cataplexy or excessive sleepiness can improve with this medication. The problem with Xyrem was that you were getting a lot of sodium with this medication. If you were on the maximum dose of Xyrem, you could be getting over 1,600 milligrams of sodium per day. So they actually came out with a different version of the medication, which has a very low sodium content at the max, like 130 milligrams at maximum dose. So it's like 92% less sodium. So essentially the same active ingredients, just kind of like corn chips, you know, regular corn chips and no salt corn chips. Still a corn chip, just how much salt are you getting? And this medication, instead of binding exclusively sodium, is binding calcium, magnesium, and potassium. Very effective medication for excessive sleepiness, very effective medication for cataplexy. This medication an individual takes when they go to bed, and then they wake up 2.5 to 4 hours later and take a second dose. The drug is somewhat sedating. That is not the point of the drug. The point of the drug is to make you feel more awake during the day and have less cataplexy, fewer episodes of cataplexy. There is a generic version of sodium oxybate in the works, but because this drug is pretty controlled, in other words, if you're an individual who has narcolepsy, you don't go to Walgreens, CVS, Duane Reade to get it. It gets shipped to you. And it's very regulated, very controlled. And as a provider of this care, it's great because they do such a good job of controlling it. It would be very difficult to get a hold of it, abuse it, and do weird things with it. The problem with the medication, however, is that you got to take it twice. Tastes really bad, and insurance can be a real problem with it. When the new version, Xywav, came out that was lower sodium, the FDA came out and said, look, this is a better drug. You should switch your patients over to this because of the risk of this high sodium burden over the lifetime of the patient. And wouldn't you know it, insurances block it left and right. They'd say, we'll provide your patient Xyrem, but we will not provide them Xywav. So essentially, Anthem, Aetna, all these insurance companies are fighting to keep patients on drugs that are high sodium when there's the exact same version of the drug, just without the high sodium right there. Same cost. In fact, I think it costs a little bit less than the Xyrem. So kudos to the insurance companies for not paying for the drug that could not only help patients with their narcolepsy, but really change their future risk for cardiovascular disease. And we know that high sodium content, I mean, think about it. The American Heart Association says you shouldn't be ingesting more than 1,500 milligrams of sodium per day. If you're on Xyrem, you could be getting 1,650 milligrams before you even put your feet on the floor and start your day. You haven't even eaten breakfast yet, and you've already passed the American Heart Association SALT recommendation. So if an insurance company is listening, come on, give us a break. Approve Xywav for patients who need it. Really don't understand insurance companies. And when I quit this seeing patients, it will be because of insurance companies, not because of my patients who I adore. So there is a generic version coming out. It's very hard to come out because they need to do all this regulatory stuff with it. So right now there's really no movement there. And there is another pharmaceutical company called Avadel, which I've done some work for too. I didn't mention that. They're coming out with a once nightly version of sodium oxybate. So back to the high salt, which is really setting up an interesting question. What do you want, patient? Once a night sodium oxybate, which is much more convenient, or twice a night sodium, potassium, magnesium, calcium oxybate, which is maybe much healthier, but you still have to wake up, 2 hours into your sleep. New version, another medication that was actually developed by Jazz, but now is owned, I believe, by Axsome Pharmaceuticals, is a drug called Sunosi, which is a dopamine and norepinephrine reuptake inhibitor. It too is a medication you take in the morning to help people feel more awake. Really useful medication, seems to work really well, cause a lot less anxiety than some of the older medications. It was really interesting when this drug came out. I would talk to other sleep doctors or the rep for Sunosi who would come by, and I would say, hey, how's the Sunosi going? Or doctors just eating it up, because we're always looking for new ways to help patients with narcolepsy feel better. And it really just kind of died on the shelf. And they said, there's a lot of providers that aren't even writing for it, touching it, trying it. They were sampling it. They wouldn't even touch the samples, which is shocking to me. And one of the things that continues to baffle me about narcolepsy is this idea that we're actually, as providers of narcolepsy care to patients, that we're killing it, that we're batting, 463, some unbelievable number if you're a baseball fan. No, we're not. There was a study not too long ago that looked at narcolepsy patients who were taking beyond the maximal dose we typically use of modafinil and full dose Xyrem, sodium oxybate. And individuals were on these medications and they were measuring sleepiness. And I think it was something like only 35% of the patients in the study were normally awake. Now, they were very improved on those medications, but if you were measuring sleepiness in those patients, 65% of them would still be considered excessively sleepy. So it's shocking to me when I meet a doctor who says, you know what? It's great that all these new medications have come out for narcolepsy, but we don't really use them that much because we're doing so well with these older medications like Ritalin and Adderall. What? What are you talking about? You are not doing better with those medications. And I'll share a quick story. When I was in residency, Fred Wooten, he was my neurology chairman at the University of Virginia. At some point when you were a senior neurologist, you had to examine a patient in front of him. And neurologists are kind of famous for their neurological examination. They have their little bag full of reflex hammers and pins and cotton swabs and little things to measure vision, all kinds of great stuff. That's the coolest thing about neurology is what's in their bag. It really is. And if you see a neurologist say, hey, show me what's in your bag, I want to see some of these cool tricks and tricks for figuring out if a patient's faking something in the emergency room. I mean, we got all kinds of good stuff in that bag. I'll tell you some more about that some other time. But so I did this great neuro exam. I remember thinking when I was done with it, Fred was going to say, Chris, that was the best neurological exam I've seen in my 50-year career. They were going to name a wing of the hospital after me. So we finished up this exam. I was feeling pretty good about myself. And we went to a room to kind of debrief. And he said something like, Chris, I'm going to fail you. I remember thinking, what? And he said, I'm going to tell you why I'm going to fail you. He said, you did a good exam. It was a very thorough exam. However, the problem is when you do a test, you're assuming, I can tell, you're assuming when you check that person's reflexes that they're going to be equal. And when you tap on them and they're equal, you've confirmed what you thought was going to happen and you move on. Never do that. You approach a patient assuming it's bad, it's abnormal, it's dysfunctional, and it's your job to prove to yourself that that hypothesis is wrong. So when you're tapping on those reflexes, you're going into it thinking these are unequal, which is not the right, which is unhealthy, which is a problem. And as you tap there and you see that they're equal, you're going to come to the conclusion that as much as I want to prove to myself that these are unequal, I can't, they're equal, then you move on. He says, Chris, if you don't do that, you will miss things. And the reason I say that is because doctors who think that they are helping their narcolepsy patients with 20 milligrams of Adderall, and they're telling me, oh yeah, it works for all my patients. You're wrong. You're going into that exam room when that patient comes back for their 6-month follow-up, and you're assuming it's great. And I'm going to tell you something. Patients want to please you. And if you ask questions in the right way, you can get a patient to say anything. Hey, Jill, how are you doing? Oh, I'm doing great. Dr. Smith, what's going on with you? Great. Still doing okay with that Adderall? Yeah, I mean, I guess it's doing, I'm doing about the same. Great. Well, you say hello to your mother and I'll see you in 6 months. I go into every exam room or every telehealth conference with a narcolepsy patient, assuming they're a mess. And it is their job during that appointment to convince me that that is not the case. They're doing great. Because I'm going to tell you something about narcolepsy patients. Here's the secret. They are wonderful at telling you they're better or they're worse. They are terrible, perhaps unable to tell you that they are normal. So when they say, Chris, this medication or medications you're giving me, I'm doing great, wonderful. That's a whole lot better than you're doing terribly. But in the back of my mind, I am thinking all the time, I can do better. I can make you better. And I'm going to keep doing that until you tell me, Chris, what you're doing for me is not moving the needle in any way. So quickly round out the rest of the medications. We've talked about Sunosi. Wakix is the last medication I want to talk about. It's an unusual drug. It is a drug that we got from Europe just a few years ago, and it works through the chemical histamine, which we've talked about before in some previous episodes. And histamine, orexin, hypocretin are very associated with each other. We've talked about histamine being the most alerting neurotransmitter in the brain, and this medication helps to potentiate histamine. All the other medications are working typically through dopamine, which makes them controlled substances. And then we have Xyrem, Xywav, Oxybate. Lumraz is the name of the once nightly version of Oxybate. They're all working through GABA B, and they're controlled substances as well too. So what sets Wakix apart is it's not a controlled substance. It's the only drug for FDA approved for narcolepsy that's not a controlled substance. B, it works through histamine. C, it actually works on excessive daytime sleepiness and cataplexy. So we have now 2 FDA approved drugs, Oxybate and pitolisant or Wakix, that treat cataplexy. And it's a pill. You take it in the morning and that's that. So we have a lot of medications at our disposal for narcolepsy. I think it's very important that if you have narcolepsy, you know somebody who has narcolepsy, I want them to make sure that they're aware, hey, yeah, I know about all these medications. I've tried a bunch of them. Because in our clinic, my job is to expose you to all of these medications. It is your job to tell me which ones you like the best. Do I think Adderall is going to solve your problem? I don't. But if you said, Chris, I've tried all these medications, you know what really works for me? 20 milligrams of Adderall 3 times a day. Hey, listen, you're the patient. You know more than I know. But I think it's very important for, even if you're a narcolepsy patient listening to this feeling like, hey, I'm taking X drug, I've never tried these other medications. I'm doing great. I'm going to push back and say, I don't believe you're doing great until you try some other medications and prove me wrong. Because I think the average narcolepsy patient is probably going to take 2 or 3 medications to feel their best. So that's it. That's really what I wanted to talk about today when it comes to narcolepsy, that there are a wide range of medications out there for you. I will mention very quickly, Xyrem, Xywav are FDA approved for children. We do use Adderall and Ritalin in young people. Technically, modafinil, armodafinil, Sunosi, Wakix are not FDA approved for individuals under the age of 18. So just kind of throwing that out there, which is very unfortunate because we're really pushing to get this medically diagnosed in young people. And then when we do, we're telling them, hey, sorry, we figured out your 14-year-old has debilitating narcolepsy. That's why they're failing other classes and been misdiagnosed with depression and ADHD. But we don't have that many medications available to them, even though they're 6'2" and weigh 200 pounds. So hopefully those things will change in the future. Don't settle for suboptimal therapy if you're a narcolepsy patient. There are support groups out there, all kinds of information out there for narcolepsy patients. DM me, hit me up if you need more information. Narcolepsy Network, find Julie Flygar and her lovely organization online, because there are resources and people out there who care. That's it. This is a Sleep Unplugged podcast. My name is Dr. Chris Winter. You can reach the show, Dr. Chris Winter Twitter, Dr. Chris Winter Instagram, Dr. Chris Winter TikTok. My books, The Sleep Solution, Why Your Sleep's Broken and How to Fix It, as well as The Rested Child, Why You're Tired, Wired, or Irritable Child May Have a Sleep Disorder and How to Help, are both available everywhere you find books. If you have a young person somewhere between birth and college years who you think might have narcolepsy, I write a lot about that in The Rested Child. Buy that book, read it, get that individual the help they need before they've decided that school is not for them because they're too tired to stay awake in class. Thanks for listening. Thanks for making this show so much fun, so popular. I love every one of you guys. If there's anything that you'd like to speak to about the show, hit us up. And until next time, sleep well.